Hi, today we are going to revise. A 65-year-old man comes to the emergency department with a substernal chest pain, a severe shortness of breath, and diaphoresis that began suddenly 40 minutes ago. The pain radiates to his left arm and does not remit with sublingual nitroglycerin. The patient has vomited twice since the pain started. Electrocardiogram shows 2 mm ST elevations in the anterior leads. On physical examination, the patient's temperature is 36.9 degrees Celsius, 98.4 Fahrenheit. Blood pressure is 110 70 mm mercury. Pulse is 60 per minute. Respirations are 32 per minute and oxygen saturation is 90% on 4 liter per minute oxygen by nasal cannula. Cardiac examination shows an S3. Lung examination shows basilar crackles that extend halfway up the lung fields bilaterally. He is given 325 mg of aspirin, 600 mg of clopidogrel, and 80 mg of atorvastatin. Which of the following is the best next step in management of this patient? Of course, the common ആയിട്ടുള്ള ഒരു ക്വസ്റ്റ്യൻ ആണ്. ദിസ് ഈസ് ദ കോമൺ കണ്ടീഷൻസ് getting. So management of this patient, the common will be furosemide. Next step in the management of this patient is giving furosemide. Furosemide is a okay. For the initial stabilization of acute ST elevation MI, as we discussed before in the ECG discussion itself, there is supplemental oxygen of if saturation is less than 90% or dyspnea is there, aspirin 325 mg, P2 Vital inhibitor like clopidogrel, nitrates are given sublingual, beta blocker are unless hypotension, bradycardia, chronic heart failure, heart block is there, we use beta blockers only if there is no hypotension, right? And high dose statin like atorvastatin 80 mg, and anticoagulation drug depends on planned revascularization, right? Persistent pain or hypertension or heart failure, we give intravenous nitroglycerin. Not if hypotension, right ventricular infarct or severe aortic stenosis occurs, we not given. When persistent severe pain, we give intravenous morphine. And IV atropine is given. Atropine is given IV in unstable sinus bradycardia. Unstable sinus bradycardia we give IV atropine, and in pulmonary edema we give IV furosemide. Not if patients is hypotensive or hypovolemic. Why? Because it causes water removal from the body. That's why. Under reperfusion, percutaneous transluminal coronary angioplasty within 90 minutes preferred. Thrombolysis if percutaneous transluminal coronary angiography not available within 120 minutes. This patient has ischemic heart failure secondary to an acute anterior wall myocardial infarction causing acute pulmonary edema. That is a flash pulmonary edema. A loop diuretic such as furosemide is the drug of choice in this setting. Furosemide rapidly relieves pulmonary edema by decreasing the cardiac preload, thereby decreasing pulmonary capillary pressure. Furosemide also causes venodilation, which further decreases the preload. However, diuretics should be given carefully in these settings, as many of these patients may be normo or hypovolemic, and aggressive diuresis may lead to hypotension and acute kidney injury. Other appropriate treatments in these situations include IV vasodilators like nitroglycerin. So this should not be avoided if the patient is hypotensive. It should also be avoided if the patient is hypotensive. What? Nitroglycerin, because it causes vasodilation. Hypotensive patient, if we give nitroglycerin, it may worsen the situation. So it is not given in the hypotensive condition. So morphine may be considered for persistent pain treatment, as it has both anxiolytic and preload reducing effects. However, it should not be used routinely due to a possible increase in mortality. Not be used more routinely due to a possible increase in mortality due to use of morphine. Ultimately, emergency revascularization for percutaneous coronary angioplasty or thrombolysis is needed for definitive management of ST elevation MI. And diuretics are recommended for acute pulmonary edema, acute myocardial infarction. Beta blockers are a standard therapy in myocardial infarction, but should be avoided in patients with decompensated congestive heart failure or bradycardia. An 84-year-old man comes to the emergency department with a 4-month history of dyspnea that has been getting worse lately. He is unable to lie flat and sleep in a chair at a night. Past medical history includes hypertension and type 2 diabetes mellitus. He was hospitalized with acute myocardial infarction 1 year ago, but has not followed up with a physician since then. His medications include aspirin and metformin. The patient's blood pressure is 144/82 mm mercury and the pulse is 98 and regular. Physical examination shows bilateral lower extremity pitting edema. The point of maximal impulse is displaced to the left and a hollow systolic murmur is heard at the apex. Lung examination shows basilar crackles. Electrocardiogram shows sinus rhythm with a non-specific ST segment and T-wave changes. Electrocardiographic evaluation and cardiac catheterization are performed to determine cardiac index, systemic vascular resistance, systemic vascular resistance and left ventricular and diastolic, left ventricular end diastolic volume, LV/EDV. Which of the following patterns is most likely to seen in this patient? Look here, the answer will be cardiac index will be low, and both LV/EDV and SVR will be high. Coming to hemodynamics in heart failure, there will be a low contractility, low cardiac output, compensated neurohormonal activation, high systemic vascular resistance and high afterload. Look, this patient's presentation is dyspnea, orthonia, pulmonary and peripheral edema. History of myocardial infarction is consistent with congestive heart failure due to the left ventricular systolic dysfunction. The hollow systolic murmur at the apex is likely due to functional mitral regurgitation, which occurs as a result of mitral annulus enlargement with the LV dilation and papillary muscle displacement due to LV remodeling. This patient's presentation, dyspnea, orthonia, pulmonary and peripheral edema. History of myocardial infarction is consistent with the congestive heart failure due to left ventricular systolic dysfunction. The hollow systolic murmur at the apex is likely due to functional mitral regurgitation, which occurs as a result of mitral annulus enlargement with LV dilatation and papillary muscle displacement due to LV remodeling. So, patients with ischemic cardiomyopathy have decreased cardiac output due to impaired myocardial contractility, a compensatory rise in neurohormonal activation like norepinephrine, renin, and antidiuretic hormone, increases systemic vascular resistance and initially maintains blood pressure and vital organ perfusion, increased blood volume due to renal sodium and water retention, increases preload and results in elevated left ventricular end diastolic volume, and hence a rise in stroke volume. However, over time, increased afterload with impaired left ventricular contractility lead to decreased cardiac output, increased left-sided pressures, pulmonary congestion, and eventually peripheral edema, that is secondary right heart failure. Cardiac index is defined as cardiac output divided by body surface area and is also reduced in heart failure. Congestive heart failure due to left ventricular systolic dysfunction is characterized by decreased cardiac output in index and increased systemic vascular resistance and an increase in left ventricular end diastolic volume. A 34-year-old woman, gravida 1 para 0, comes to the office at a 38 weeks gestation due to increasing shortness of breath. The patient says that the pregnancy is causing too much discomfort at this stage and requests delivery. She cannot find a comfortable position to sleep in, and after walking several steps, she needs to stop to catch her breath. But the patient's pregnancy has been uncomplicated and she has no significant medical problems. She does not use alcohol or tobacco. Blood pressure is 130 to 85 millimeter mercury and pulse is 102 and regular. A third heart sound is present on cardiac auscultation. There is a new grade 2-6 hollow systolic murmur at the apex. Pitting edema is present over the lower extremities. Urinalysis shows trace protein. ECG shows sinus tachycardia. Which of the following is the best next step in the management of this patient? Of course, the best next step in the management of this patient is echocardiogram. Sure. Why? Because the clinical features of peripartum cardiomyopathy, onset of heart failure during the last month of pregnancy or within 5 months following delivery is peripartum cardiomyopathy, right? Left ventricular systolic dysfunction with the LV ejection fraction less than 45%, absence of other causes of heart failure, and absence of heart disease prior to final month of pregnancy. Here the short break. We will get back to next question soon.